Welcome everyone. And I'm very happy to see all of this gathering. This is a webinar part from our series of activities and scientific events. We are focusing on CRRT, and we have a panel of expertise. I'm Professor Amr El-Husseini, a professor of nephrology. We have Professor Manu Melbourne, who is a professor of critical care in Dublin. And we have Dr. Fadel Ibrahim, who is a consultant of critical care from Egypt, and he's practicing in King Abdulaziz University Hospital in Jeddah. Dr. Craig is going to give us a fantastic presentation about CRRT nomenclatures. He's a senior consultant, critical care nephrologist in South Africa. Dr. Kamel Attar is going to show us a demonstration on the CRRT machine, very fantastic interactive session. Today he's from Baxter International Company. Dr. Marcus Pruman, who is a senior consultant, and he is practicing in United Arab Emirates. He's from Sweden. Dr. Jacob Bacrizia, who is a consultant in Portugal, practicing in Spain. They are both going to moderate the session with Dr. Manu Melbourne. And here is our brief agenda today. We'll start with a case-based discussion focusing on CRRT troubleshooting with Dr. Fadel Ibrahim. Then with Dr. Craig, he's going to focus on the new CRRT terminologies and nomenclature. Then Dr. Kamel Attar will focus on the anticoagulation, especially the regional secrete anticoagulation. Then Dr. Marcos and Dr. Jacob are going to help Dr. Kamel to answer the question. Then the closing remarks will be conducted by Dr. Manu Melbourne. So please try to put your questions in the QA box if you have any. And also, please try to activate the show caption. When you activate the show caption, you can see the transcription, whatever we are saying verbally, you can see it on the screen. And now we are going to start our first part with Dr. Fadel case-based discussion.
Good evening, everyone. Welcome to our webinar for our CRRT crash course that will be held in November 18 and 19, 2025. Today, we will discuss a case-based discussion for this webinar. This is a 65 years old man with hypertension, diabetes. It is admitted to our ICU with a septic shock from pneumonia. He was intubated on PRVC mode on vasopressors in the form of norepinephrine 0.3 mic per kg per minute, vasopressin of 0.02 unit per minute, and he was anuric. Our intensivist decided to start for him a CVVHDF for AKI and fluid overload. He is on regional citrate anticoagulation. The CRRT machine is continuing alarm for high transmembrane pressure every 12 and 14 hours, leading to circuit loss. This is our first MCQ. Which of the following critical components for the RCA circuit is missing from this diagram? A, citrate pre-filter infusion line. B, effluent ultrafiltration collecting bag. C, ionized calcium sampling port. D, calcium chloride infusion line. E, heparin infusion line. The answer is the ionized calcium sampling port. While all options are a part of the CRRT circuit, ionized calcium sampling port is the most critical missing label for a safe regional citrate anticoagulation. The principle of RCA is to chelate ionized calcium in extracorporeal circuit to prevent clotting. Patient systemic ionized calcium must be meticulously monitored and maintained within a normal range. The missing label, the ionized calcium sampling port, is typically located on the patient's arterial line. This is pre-circuit. Its absence from the diagram highlighted a failure to identify the primary safety monitoring point for preventing life-threatening hypocalcemia in this patient. MCQ number 2. What is the most likely primary reason for the recurrent circuit clotting in this patient on RCA? High blood flow rate, citrate accumulation syndrome, elevated filtration fraction, low ionized calcium level, or machine malfunction? The answer is elevated filtration fraction. Elevated filtration fraction is a critical factor contributing to recurrent circuit clotting during the RCA. Filtration fraction is defined as a ratio of the ultrafiltrate rate to the plasma water flow rate. When the filtration fraction is too high, typically above 20 to 25%, it leads to hemoconcentration within the filter. This increases the viscosity of the blood and promotes the activation of the coagulation cascade, even in the presence of adequate anticoagulation like citrate. In RCA, citrate chelates calcium to prevent clotting in the extracorporeal circuit. However, if hemoconcentration occurs due to high filtration fraction, the anticoagulation effect of citrate will be overwhelmed, leading to a premature filter clotting. This phenomena is well documented in the clinical practice and supported by the nephrology guidelines and studies. This is one study by Schneider et al. At 2017. MCQ number 3. Which lab finding is most suggestive of the citrate accumulation in this patient? Systemic ionized calcium. 1. Total calcium to ionized calcium ratio above 2.5. Serum sodium of 155. Serum bicarb of 10. Platelet count less than 50,000. The answer is total calcium to ionized calcium ratio is above 2.5. The answer explanation is the total calcium to the ionized calcium ratio becomes a sensitive marker for citrate accumulation. Ratio greater than 2.5 is considered highly suggestive. This diagram is answering our question very clearly. This is in the normal patient without CRRT, without connecting to citrate. We have small amount of calcium citrate in our blood, and this is all the total calcium. This is the calcium bound protein, this portion, and this is the ionized calcium. So all the calcium of the three parts are considered as the total calcium. When the patient is connected to CRRT circuit with RCA original citrate anticoagulation, the ionized calcium still the same, the calcium bound protein is still the same, and the calcium citrate increase. When there is accumulation of citrate, the calcium citrate complex will increase in the absence or in the leading of the ionized calcium, leading to a ratio of greater than 2.5. This all calcium to the ionized calcium ratio is greater than 2.5. This is in the citrate toxicity or accumulation. MCQ number 4. If the patient had a history of heparin-induced thrombocytopenia, which anticoagulation would be preferred alternative? Unfractionated heparin, low molecular weight heparin, argatropan, no anticoagulation, or aspirin? The answer is argatropan. Argatropan is a direct thrombin inhibitor that binds reversibly to the thrombin and inhibit its activity. It is an FDA-approved specific for the treatment of HET or the heparin-induced thrombocytopenia. Unlike heparin derivatives, argatropan does not cross-react with the HET antibodies, making it a safe, effective alternative. It is administered intravenously and monitored using the APTT. Its hepatic metabolism makes it suitable for patients with renal impairment, which is often the case in the CRRT settings. Thank you.
Thank you so much. Very nice case-based discussion. And again, please remember, if you are looking for the citrate toxicity, you need to focus on the calcium gap. So the ratio of total calcium to ionized calcium will be higher than 2.5. Of course, there will be acidosis, hypernatremia, and other signs, but this would be the clue for diagnosis. It's very sensitive and specific test. And if you have had heparin-induced thrombocytopenia, please don't use unfractionated or low molecular weight heparin, but rather use argatroban. Now, it's our champion, Dr. Craig, who is one of our critical care nephrology board member, who I know from at least 3 years now. And we have been collaborating very well through different educational events and scientific activities. He is a hero when it comes to critical care nephrology and CRRT teaching. He is one of our board members in several fellowship and programs and courses. Today, he is going to teach us something new, which is the terminology, the nomenclature for CRRT. Please go ahead, Dr. Craig.
Thank you very much. Let me just get my slides up here. Am I sharing? Am I sharing, Dr. Ahmed?
Yes, sir.
Okay. Right. Good evening, everyone from sunny Cape Town in South Africa. A warm good evening to my colleagues and my fellow board members. It's once again a great privilege to be on the platform with you. The topic of my talk is going to try to cover just a very few of the nomenclatures that we use on a day-by-day basis in continuous renal replacement therapy. And this is a very important starting point because the nomenclature in this speciality is particularly daunting to those who are new to it and who don't really deal with the nomenclature on a day-by-day basis. It is highly technical, and it can really cause a lot of confusion from the start, not to mention the fact that, you know, CRRT is not done by each and every one of you on a daily basis like I do it. But you may be surprised at the terms that I'm going to address today, because the very basics start with our very fundamental understanding of what the word continuous means in continuous renal replacement therapy. I'm going to talk about the concept of efficiency in CRRT. The issue of body weight, you may be surprised, but is very important and causes a lot of confusion and uncertainty in the space. My colleague has already spoken a little bit about filtration fraction, and I'll break it down to an even simpler concept for you. The flow rates are very confusing to those who are new to this, and there's also basic understanding that needs to come from that. And then the various terminologies that use filtration can also become confusing. Let's start with this, the meaning of the word continuous in CRRT. Now, the note textbook will explain this to you in clear terms, but as the name suggests, the C in CRRT means continuous. And there is a lot of confusion then that stems from the misconception of this thing. CRRT is not referring to a specific machine. CRRT also does not refer to a type or a class or a size of filter. CRRT is not the same, and it cannot be compared to other modalities like intermittent renal replacement therapies modalities and SLED. And maybe you'll frown when I tell you that CRRT is not 24-hour treatment. What CRRT really is CRRT is built around the core principle that you are giving truly continuous therapy. In other words, your patient needs renal replacement therapy for as long as that patient requires it and has acute renal failure. More so, CRRT is quite important in that it must be to the standard of care of a completely uninterrupted session. And with modern technology, and particularly I'm referring here to the use of regional citrate anticoagulation, this is achievable for up to 96 hours and even more. I have personally run a patient to as long as 110 hours on a single uninterrupted therapy session on CRRT. And then a core concept to understand also is that this is a form of therapy that has a very slow effect. And I'll get to the term low efficiency a little bit later. But we often confuse the fact because we use a different machine and we use different filters that it's got to do with all these things, but it really only has to do with a process that happens continuously in an uninterrupted fashion and in a very low efficiency, slow modality. CRRT therapy is focused around patient stability. It's focused around achieving fluid overloaded management. It's focused around controlling metabolites. And ultimately, we are using this form of therapy to protect organs. And we should really think about this machine as one that we don't use in a broken fashion as we do our intermittent therapies. We use it day in and day out, and that therapy is running continuously. And I say this because a lot of textbooks might make you believe that we're talking about a 24-hour treatment period. But if your patient is unwell for a week, you cannot compare 72 hours or 96 hours of CRRT with intermittent periods of intermittent hemodialysis therapies. The difference between those two therapies is just too great and should not really be compared, in my opinion. Now let's look at this concept of efficiency. Efficiency in renal replacement really means that you aim for a successful completion of a therapeutic task, and that speaks about effectivity. We also want to complete this therapeutic task within a predetermined time frame, and therefore you have to think about how fast or the speed with which you do your therapy. And ultimately, we want to achieve our clinical outcomes, which dictates the quality. So efficiency is really a mixture of how rapidly and consistently we are able to achieve renal replacement therapy with the prescribed goals of solid clearance and fluid removal. I've put the term prescribed treatment because with CRRT, we really should not be in a state where we hesitate how long our therapy is able to last. And once again, we'll come back to the very important concept of using regional citrate anticoagulation as your most likely anticoagulant and therapeutic intervention that will allow you to, with accuracy, prescribe dialysis for a certain speed and certain length of time. The degree to which renal replacement therapy successfully provides your hemodynamic stability and physiological equilibrium is also built into this, into your ability to be able to use your therapy over a preferred period of time and not be put into a position where you have to provide a certain amount of clearance and fluid removal within a period of time that is going to compromise the patient. So the key metrics in renal replacement therapy is solid clearance, the fluid removal rate, which I'll speak about a bit later, your treatment duration, and this is a treatment that you decide on as the clinician treating your patient. You need to decide on whether you can achieve your targets within a 24, 48, 72, or 96-hour period. Membrane survival and performance is really the Achilles heel in this equation, because we often have to discontinue our therapy simply because we are unable to make sure that our membrane survives adequately. And patient stability is paramount. And the reason why we bring low efficiency CRRT into the ICU is because we are most interested in patient stability while we are conducting this therapeutic modality. So CRRT in the form of continuous therapy provides a low efficiency form of therapy. This is focused on consistently achieving a continuous, slow solid clearance and fluid removal, which is well over 24 hours and can go on, as I said, up to 96 hours, with, most importantly, with consideration of the possible metabolic and hemodynamic effects that you are doing with that machine. Intermittent therapies, you are really not that considerate about whether the patient is metabolically or hemodynamically affected by this, because that you would not use intermittent therapies in patients who are highly stable. I like to use an analogy where to show this equality of efficacy, in that, you know, if you have a bus full of school kids needing to get to school compared to a parent taking that child to school, obviously the one will get there quicker, but the safety of the bus getting to the school and the speed with which the individual learner gets to the school has to be weighed up on the speed with which you give that trip. Both of those parties reaching the school reaches the same efficacy, and there is no insistence that the bus gets there at the same time as the school. This is a poor analogy, I think, but for me, I always think about it that I'm as effective with a slow means of therapy as I am with a high means of therapy, and maybe even safer. We often hear these words in renal replacement therapy: prolonged treatment and sustained therapies. And we use many forms of hybrid therapies, which really is a bridge between intermittent and continuous renal replacement therapies, and it offers us flexibility. The question that I really have for all of you is, when you're talking about these bridge and these hybrid therapies, are we really talking about, are we measuring it against patients who have various complexities, or are we really just talking about our complexities around our skills and the resources that we are able to use? Once again, I'm coming back to the issue of continuous renal replacement therapy with regional citrate anticoagulation, because oftentimes prolonged intermittent renal replacement therapies, which is essentially just an extended form of therapy, sometimes can go up to 8 hours or even up to 24 hours, gives very little consideration to the patient's metabolic and hemodynamic stability. But it is a valuable option when CRRT resources are limited, especially when you're unable to maintain the circuit integrity. And this is really because of inferior circuit anticoagulation strategies. The same, I would argue, goes for sustained low efficiency dialysis therapies, which is really just one type of prolonged intermittent therapy. Typically, it's given over 10 hours with low pump speeds and low dialysis speeds. But because you are forced into giving your patient a very short period of therapy, you're really offering the patient very little consideration for the hemodynamic effects that is going to come from you doing that therapy in such a short and rapid period of time. And I would argue that people utilize SLED therapy really as, once again, lacking the resources and skills that would allow you to do continuous, uninterrupted dialysis therapy due to poor anticoagulation and ability to sustain the filter life. The topic of what weight we use in continuous renal replacement therapy is more confusing than you would imagine. And this is very often a talking point when it comes to what weight we choose and how we dial these weights into various things within this space. The actual body weight, as you all would know, is notoriously difficult, first of all, to achieve, difficult to get in an ICU setting. And even when you use a known actual body weight, what you're really doing here is you're using a patient's measured or estimated measured weight. And this really is an inaccurate proxy for fluid status. Yet we hang quite a lot of we base a lot of our major decisions on just an actual body weight, such as the effluent dose targets, such as ultrafiltration rate targets. And we even use this actual body weight for medication dosing, bearing in mind that the medication dosing can overestimate fluid needs in fluid overloaded patients. The alternative to use is what we call a predicted body weight. And this is really just a calculation of height and gender. These are examples of how it's done. And it is in many more recent papers has been described as possibly the more preferred body weight to use if you are able to get these basic height and height calculations of the patient. The long and the short of using a body weight is we need to have a conceptualization of what our patient's physiological steady state weight is versus a patient who is overloaded on the one hand with the so-called wet weight as we use in nephrology, and on the other end with the so-called dry weight, which implies that the patient has been adequately ultrafiltrated and dialyzed. And really, this is quite a crucial topic and will be discussed in more detail when we do our crash course in a few weeks' time. In order for us to really understand what weight to use is really an effective, a crucial point in doing effective fluid management and medication dosing in the CRRT patient. The issue of blood pump and flow rates causes a lot of confusion. And this is once again because not all of you are in a position where you use and prescribe these flow rates on a day-by-day basis, possibly just once or twice in a month when you're doing CRRT. But it is really, in order to optimize CRRT therapy, we need an understanding of the relationship between blood pump speeds and dialysate pump speeds. But an important concept that I just want to bring across is that the blood pump speed and the rate of blood, which is the rate of blood circulation through our filter, higher rates are for faster solute clearance. And this is only really relevant when you're using high efficiency therapies. And optimizing your blood flow rate and your dialysate rate is a priority in low efficiency effectiveness. So just increasing your pump speed, really you have to think about the speed at which you are offering clearance and not really necessarily giving better clearances. The dialysate flow as well, measured typically in moles per hour on CRRT. Higher rates of dialysate flow rates gives you faster solid clearance, not necessarily better solid clearance. And this is because you get more diffusion the faster your dialysate flow rates are set. Increasing dialysate rates per se has no effect on filtration fraction. And then replacement fluids is the amount of essentially the convection that we offer the patient. And here, once again, higher convection rates or higher replacement fluid rates, once again, offers faster solid clearance. I just want you to focus on this in that faster does not necessarily mean better, and slower does not necessarily mean worse. So we don't think about continuous renal replacement therapy as something that is inferior to intermittent therapies. They both will bring about the same effect, just over a different period of time. My colleague has already spoken a little bit about filtration fraction. Well, my take on filtration fraction is really that this is the poor man's predictor of circuit longevity. But I want to offer you a very simplistic working concept, because the understanding of filtration fraction is important, but it is so technical that once again, you are going to be stumped if you try to remember it and you're not doing CRRT on a regular basis. Effectively, it's the convection indexed to the blood flow. The more convection we give, the higher the filtration fraction will be. The less blood flow we give, the lower the filtration fraction will be, and vice versa. And it is an interplay between these two concepts. And as was said before, we aim to keep it well below 20% and really as low as possible below that level. But once you get to a filtration of above 25, you're really looking at a very high risk of the filter clotting. But I want to stress this important fact that filtration fraction reduction is not a form of anticoagulation. We should not walk away from the concept of filtration fraction thinking that if I'm able to reduce filtration fraction to as much as possible, I will not clot my filter. It is not a form of anticoagulation, and it is not therefore to be considered as a means of keeping your filter running for long periods without using regional citrate anticoagulation or heparin if you choose them for that matter. Just a little funny one. If anyone asks you to calculate filtration fraction, your answer really should be that you are a clinician and not a mathematician. The machines give us the answer to filtration fraction these days, and The calculation, although academic, you don't have to understand it, but the concept of convection and blood flow needs to be understood. There are many of these terms that go around in continuous renal replacement therapy: fluid removal rate, ultrafiltration rate, fluid balance, fluid accumulation, fluid overload. And this can become very confusing at times. But the important one to know about is net ultrafiltration rate, right? And this is really a concept that we will teach on in our masterclass and in our crash course, because this is really the target that we are using, or the metric that we are using to gain precision fluid management. The ultrafiltration rate, you all will have seen a patient fluid removal rate. That is the rate that you punch in your machine and the amount of ultrafiltration that the machine is producing into the effluent. But the net ultrafiltration rate is actually the fluid that is removed from the patient per hour, which includes all the removal of all the excess fluids that are also given to the patient. And it is a balance of fluids within the patient. And this is the ultrafiltration rate that we need to achieve in order to bring a patient into a certain target of fluid balance. This is typically the ultrafiltration net rate that is being recommended in patients who are relatively unstable in a de-escalation phase of ICU therapy. And this is also the numbers that we have to begin to understand and work towards. Low fluid removal rates around about the less than 1 mol per kg per hour, moderate rates in this 1 to 1.75 moles per kg per hour, and higher rates when the patient are more stable, really goes to above 1.75 moles per kg per hour. So why are these terms important to know? Continuous efficiency, body weight filtration fraction, flow rates, ultrafiltration. Well, if you're going to practice CRRT with any amount of precision, we all need to understand these parameters. We need to understand how to prescribe them. We need to understand how to administer to the patient without guesswork, and to avoid basically complications of either underdosing, overdosing, or undertreating or overtreating the patient. It all becomes very important because these parameters and others that I haven't spoken about, really a clear comprehension of the modalities, which we'll speak a lot about in our crash course, and other parameters around fluid management becomes important in maintaining hemodynamics and achieving therapeutic goals. And standardizing terminology facilitates very clear communication amongst interdisciplinary teams. So everyone knows what we're talking about, everyone understands what it means, and the patient benefits from all of this. That's all I have. Thank you very much.
Thank you so much, Dr. Craig, for this fantastic presentation. Again, all what we are talking about is very clinically helpful, and we are going to teach you more and more in our November 18th and 19th webinar. We have in November 18th and 19th masterclass CRRT crash course for 2 days. Each day is 6 hours from 4 p.m. Mecca time to 10 p.m. So 6 hours, including 4 hours of education and 2 hours of engagement with tasks and assignments through our smart platform, including a lot of live demonstration, real case scenarios, and clinical practice session and CRRT certifications. And we have a panel of expertise between critical care physician and nephrologists from all over the world. So it's 100% online virtual workshop that is going to focus on CRRT principles, troubleshooting, pitfalls, CRRT initial settings, monitoring, point of care ultrasound and hemodynamic assessment, Also ultrafiltration, fluid management, understanding the core principle of CRRT and other different slow dialysis modalities. We are going to focus on the troubleshooting, optimize CRRT machine, dialysis adequacy, explore novel CRRT technologies, use of artificial intelligence, simulators, calculators, and CRRT prescription and management. And we are hoping that you are going to master the CRRT prescription, fluid management, assessment, ultrafiltration, and hopefully you can apply this very important simulated knowledge in your clinical practice to improve your patient's care. It's not only that, but also we have a session for abstract. So please, if you have any interesting patients with acute kidney injury who require dialysis, especially who require CRRT, any interesting case reports or case series or a small study and you want to share with us, please feel free to submit your abstract. The abstract submission deadline is Monday 20. So it's only 7 days from now to close the door. Again, if you are interested to join this virtual workshop and crash course, the master class for 20 our accredited certificates from the American Association of Continuing Medical Education, please go ahead and apply, and you can use the promo code webinar 10 to get 10% discount. What we are doing is trying to help people, especially in the developing countries and low-income settings, to get better explanation, better understanding of the basics and advanced technology of the CRRT. We want to apply more, advanced knowledge in the CRRT practice. Now we are going to listen and to watch this very nice demonstration from Dr. Amr El-Husseini about a case-based discussion of a patient who requires CRRT secondary to trauma.
Now, a lot of us see trauma cases, and I wanted to share with you maybe one case study so we can look into the citrate anticoagulation prescription. Typically a 29-year-old male patient, 98 kilos, 167 centimeter tall, admitted to the emergency room, polytrauma following a motor car accident. Patient has numerous superficial wounds, severe pain, bruising of the chest, distension of the abdomen. CT reveals lacerated liver, ruptured spleen, subclinic hematoma, chest X-ray reveals broken ribs, right-sided hemothorax. Blood pressure starts to drop and his conscious level deteriorates. He receives 2 more units of blood in the emergency room. The decision was made to perform an emergency laparotomy. Operation lasts for 8 hours, during which surgeons repair the liver, drain the hematoma, patient blood pressure starts to drop further. He receives 4 more units of blood intraoperative, is admitted to the ICU post-op on mechanical ventilator with a MAP of 65, a dose of 20 mic per minute, norepinephrine. His labs reveal creatinine 2.3, potassium 6.5, sodium 125, lactate 3, pH 7.21, bicarb 18, hemoglobin 6, platelets 50,000. His urine output was 300 cc in the past 12 hours. What is his current KDIGO staging? Now, stage A would be no AKI, stage 0, B, AKI stage 1, C, AKI stage 2, and D, AKI stage 3. The correct answer is the oliguria, as you can see, 300 cc. If you divide them by the weight of the patient, which is around 100, is 0.3, which is oliguria, in the past 12 hours. So the oliguria is more than 6 hours, and now it's more than 12 hours. So when we say oliguria is more than 12 hours, which stage is that by the KDIGO? You see for the KDIGO criteria, oliguria persistent for longer than 12 hours means that it's a stage 2 AKI. So the correct answer is C, stage 2 AKI. Now, would you start RRT with those parameters or would you wait? would you look at these parameters? Would you start RRT or would you wait? A, start RRT, B, wait. Now, some of you will choose to start RRT because of the, as you can see, the potassium is high, so it's a hyperkalemia. You can also see pH is low, so it's acidotic. Some people would choose to wait because there is nothing really very dangerous about that. So this question is a great question. It's one of the cases where some physicians would start RRT and some physicians would wait. So in this case, it's not a right or wrong answer, and both answers work very well for that case. But the decision here was made to start the RRT. The doctors have designed a full CRRT prescription using regional citrate anticoagulation, including blood pump, dialysate, post-dilution, calcium replacement percentage, and the citrate dose. This is how you fill in the CRRT prescription. Remember, the weight of the patient is 98. Doctors prescribe CVV HDF prescription using the Prismaflex with 3 millimole citrate according to the CRRT protocol, which we explained earlier. What would be the blood pump, the dialysate, and the post replacement? A, 130 ml per minute blood pump, 1.3 liter dialysate, 0.5 replacement. B, 140 ml blood pump, 1.4 dialysate, 500 replacement. C, 150 ml per minute blood pump, 1.5 liter dialysate, and 600 ml post. D, 150 ml per minute blood pump, 1.6 liters of dialysate, and 700 post. So remember the protocol we used, the CRRT protocol. Patient is 98 kilos. We approximate to the nearest 100, so it becomes 100 kilos. The correct answer would be 150 of blood pump, 1.5 liter dialysate, and 600 of replacement. The correct answer here would be C. So in that case, you start uploading the prescription. You can see that here is the patient the review prescription. You want to do the flow settings. You want to have the blood pump, as we explained, to be 150. You want the dialysate to be 1.5 liters. You want the replacement to be 600 ml per hour. Now, should I also enter the pre? The answer is no. The pre is going to be automatically entered. This is how you enter the CRRT prescription. That's it. It's 3 millimoles. So the citrate is 3 millimoles. And that's it, confirming all. And confirm all now, 3 millimoles of citrate. You can see the blood pump 150. Of course, the machine will automatically adjust the pre-blood pump, will automatically adjust also the calcium replacement pump to be 100%. So you put this at 100%, and then you confirm all, and these are the parameters. Of course, here the machine gives you the warning that metabolic disturbances are common with citrate, and here you can see the main screen of the flow rates. You continue, you connect the patient, and this phase, patient start the treatment. And this is the main screen when we start the patient, 98 kilos, blood pump 150. Pre was automatically done by the machine at 1.5 liters. You see the dialysate, it's 1.5 liters, replacement 600. The dose is now 37 ml per kg per hour, and therefore this delivers 3 millimole citrate. How do I know that? You adjust anticoagulation. When you press the anticoagulation, you see the anticoagulation menu. You see the citrate. We're using Prismocitrate 18.0. The citrate dose is 3 millimole, and you put 100% calcium compensation. So this is how you enter the CRRT CVHF citrate anticoagulation prescription on the machine. Now the machine is running. Everything is going as planned. CRRT is running fine. 4 hours after starting the CRRT, labs reveal the sodium is 130, potassium is 6. Remember, sodium was 125, potassium was 6.5. What changes to the CRRT prescription would you make? A, increase the dialysate to increase the CRRT dose and improve the potassium clearance. B, switch dialysate from the Prismocan to a zero potassium solution, which is, for example, dialysate or Imosol BO. C, increase the blood pump from 150 to 160 ml per minute to increase potassium clearance. D, monitor sodium closely to avoid rapid correction of hyponatremia. So these are the 4 options. You are allowed one change only. What would you make? Now, let's look at them one by one. Patient potassium was 6.5. After 4 hours of CRRT, it is now 6. This is considered very good clearance. In CRRT, we target correction of potassium over 24 hours. If we see a 0.5 correction in 4 hours, this is considered good clearance. So in general, there is no problem with potassium clearance. So in general, AE could hypothetically increase the potassium clearance of potassium, yet we do not have that much problem. So A is correct, but not the right answer. B, switching dialysate to Imosol BO. Imosol BO or dialysate are normal CRRT solutions. Remember, they have calcium. And if they have calcium, you're going to introduce calcium to the circuit, you end up with clotting. They're also high bicarbonate solutions, so you end up with alkalosis. So B is not the right answer. C, increasing the blood pump from 150 to 160 increases potassium clearance. Now, this is again true for intermittent therapies. When we increase the blood pump speed from 150 to 200 or 300, we increase the clearance of all solutes, including potassium. But in CRRT, the dose is more important. So if you wanted to increase the clearance, probably increasing the dose would be the better answer. A, not C. But C, in that case, does not make any benefit for potassium removal. So the correct answer is D, monitor sodium closely to avoid correction of hyponatremia. We know the sodium was 125. 4 hours later, it's 130. You need to start looking to monitoring. It's not very dangerous, as we understand, but if we are in 4 hours going from 125 to 130, maybe the rapid correction is going to be dangerous for the patient. So the correct answer here is D. 6 hours after starting the treatment, the nurse comes again with another ABG, patient serum ionized calcium 1.4, post-filter ionized calcium 0.1, bicarbonate is 24 millimoles. What changes to the CRRT prescription would you make? Remember, the prescription is as is, blood pump 150, citrate 1.5, dialysate 1.5, replacement 600, 3 millimoles, and 100% calcium compensation. A, increasing citrate dose from 3 to 3.5 to lower patient ionized calcium. B, increase calcium compensation to 110% to increase post-filter ionized calcium. C, increase both calcium compensation to 110, citrate dose to 3.5. D, decrease both calcium compensation to 90% and citrate dose to 2.5. Now, those of you who are paying attention to the first presentation, the second most important slide was this one. Remember, we talked about the 9 possibilities of having high patient, normal patient, low patient, high filter, normal filter, low filter. And remember this possibility, we had one possibility where there's high patient, as you can see, but low filter. Where is that quadrant? Which quadrant is that one? High patient above 1.2. In this case, you can see the lower left quadrant, where you have high patient, low filter. And in this case, the correct answer is decrease calcium compensation to 90 degrees and decrease citrate dose from 3 millimole to 2.5. So decrease and decrease. How did I know that? From following the Kalmar protocol, you can take a look at it. Now, the nurse's instruction is go from 3 millimole to 2.5. How does the nurse do that? Very easily. They go to the anticoagulation menu. They adjust. They go from 3 millimoles of citrate to 2.5 millimole of citrate. They confirm, and that is now the menu as is changed. You go back, and this is also go to the same with the calcium. In this case, decrease from 100% down to 90%. So this is how simple it is to adjust the dose. It took 1 second on the machine. Now we can continue the treatment. 8 hours into the session, patient serum ionized calcium is 1.2, post-filter ionized calcium is 0.3, and bicarbonate is 16. What changes to the CRRT prescription would you make? A, increase dialysis to increase bicarbonate diffusion from dialysis to patient blood. B, decrease dialysis to decrease bicarbonate delivery from the plasmocitrate 18-0. C, decrease citrate dose to 2.5. D, add sodium bicarbonate amps to the plasmocitrate bag. Now, increasing dialysate to increase bicarbonate diffusion from dialysis to patient blood is what you would do in a heparin or a no anticoagulation treatment. Why? Because this is a small molecule that passes by diffusion. The faster the dialysate, the faster will be the diffusion. So what you normally do is increase the dialysate flow from 1.5 to 1.6 ml per hour. In this case, you will improve, yes, you will improve the diffusion of bicarbonate towards the patient. But in bicarbonate, in citrate therapy, it is quite the opposite. In citrate therapy, you remember, the dialysate is a B22, is the one with the low composition. In this case, this is the one that we want to do less. The one with the high bicarbonate composition is the citrate, the plasmocitrate. 18 millimoles becomes 54 millimoles of bicarbonate. So if I decrease the dialysate, I will end up with more bicarbonate. So reducing the B22, you will end up with a higher patient net buffer load. The patient will get more bicarbonate from the plasmocitrate. Another thing is maybe increase the citrate, but you don't want to play with the citrate because already the patient's serum annualized calcium is now normal. The filter post annualized calcium normal. Don't touch the citrate. So either increase the citrate or reduce the dialysate. But we don't want to play with the citrate, just to reduce the dialysate from 1.5 to 1.4 or 1.3 milliliter per hour. So the correct answer is B. Now, why is C incorrect? C is absolutely incorrect because decreasing citrate, again, will decrease the net buffer load, will decrease the bicarbonate. So we going from 3 millimole to 2.5, you will end up with with less bicarbonate delivery. So C is incorrect. D, add sodium bicarbonate ampoules to the plasmocitrate bag. Now, some practices, doctors add sodium bicarbonate to the CRRT circuit. In some hospitals, this is considered common practice. But if you want to do that, don't add it to the pre, add it to the post, add it to the foxilium. Why? Because if you add it to the pre, then it will be dialyzed. It will be removed from the filter. It will be removed in the dialysate. So D is not a correct answer. I hope you enjoyed the practical case. You know, citrate is better practiced than learned. It's easier to do it than to discuss it or read about it. I wish you the best of luck with your citrate programs and the best of luck with the rest of your training. My name again is Dr.
So, Dr. Marcus, please go ahead and lead the webinar.
So I cannot see any question from my side here, but I have a question from myself. Clinically, doctors are often worried about the treatment dose. In the beginning, when the patient has been anuric for a while and the metabolic acidosis is very strong, we have hyperkalemia there, we want to start with a bigger treatment dose, a higher treatment dose. And then when the patient stabilizes, we get better values on the homeostasis. We want to reduce the treatment dose, and we think that the patient might not need so much dialysis. Now we should just do a little bit of treatment and keep the homeostasis. So my question to the speakers, mostly to Dr. Craig, will be that given the concept treatment dose nowadays, the effluent flow is used as a template for the treatment dose. We look at the effluent flow. So how exact is the effluent flow regarding describing the treatment dose? For instance, if we increase the blood flow with the same effluent flow, the treatment dose will go up. If we change the content of the dialysis fluid and create bigger gradients, the treatment dose will also go up. So what is the comment of treatment dose? And also, this will be a very long question. Should the treatment dose be monitored hourly, or should we go on a longer period of time when we talk about the treatment dose? So what can be said about the treatment dose? This is my question.
Okay, I mean it's one of the ultimate questions that we face when we are dealing with a very toxic patient who we want to see the clinical evidence that we are improving things, you know, on a continuous basis. But I think it boils down to your, you know, a lot of the topics that we will deal with also is on the timing of the initiation of therapy. If you're going to delay therapy unnecessarily for a continuous period of time, waiting for numbers to breach certain thresholds, you almost invariably going to sit with a patient that is very severely uremic, very severely hyperkalemic. So I think one of the principles that we must know about and teach really is that dialysis, especially CRRT therapy or any dialysis, be it for that matter, needs to be started in a very timely fashion, and not in a fashion where we are trying to rescue a patient's life with a dialysis machine. That is, I don't think dialysis is meant to save lives in that way. The second thing I would just like to say is that, you know, as a nephrologist who practices both acute care and a lot of, I think 80% of my work is managing patients in the hemodialysis units that we have. You know, you're treating patients in a stable patient in a hemodialysis unit with clearance equivalent to about 200 and 250. And you can often compare those to what we're doing on a CRRT machine, which is about 20, 25, and 30. And if you look at the starking difference between what we do on a patient with an intermittent session over typically a 4-hour period, clearances of 200, 250, you have to realize that CRRT is designed to give slow, gentle therapy over a longer period of time. You cannot have an expectation from a CRRT machine to do things faster because it's not made for that. And your patient who is severely hyperkalemic, you need to literally rescue from hyperkalemia, probably will need an intermittent session to start off with. And then once you are happy that the acidosis and the hyperkalemia is adequately addressed, then you could change the patient to a more continuous form of therapy. But I don't think we must think of CRRT therapy as something we can tweak to rapidly do something, because that is not the role and that is not how CRRT is meant to be prescribed.
Can we say that we are protected when using CRRT? We are a little bit protected regarding overtreatment, because clinicians are also afraid of disequilibrium phenomena and over-treating the patients and having the osmolality change too fast. So can we say that by using CRRT, we are in a way protected against this?
I would go a step further and say that disequilibrium syndrome is impossible with CRRT therapy.
True, yes.
You cannot make a patient, disequilibrate a patient with the use of CRRT therapy. I think this has been written about, and it's been proven scientifically also that it is impossible to disequilibrate a patient with CRRT.
So by summarizing, we should learn to read the circuit, understand all the parameters, as we have nicely seen here. Also to understand the contents of the treatment fluids, and to basically understand the circuit as a whole, And this will help us to design and to prescribe a correct treatment. I will switch gear here and come up with my second question. Now then that we have the citrate anticoagulation coming and becoming established throughout the world, the filters will stay viable longer regarding the anticoagulation, and we can use them past 72 hours. That was a magical number before. No filter was basically going past 72 hours. So what parameters could we use to estimate how viable the filter is when it becomes more old? Because we know that there are other phenomena taking down the viability of the filter, not only the anticoagulation. For instance, there can happen clogging, so that certain channels of the filters will be basically obstructed, so there is going no blood through these channels, and subsequently taking down the treatment viability of the filter. So if a filter is running on a machine, the filter is becoming older, how can we realize and monitor how well the filter is doing its work? What would the comment be on this? Because I think that this question starts to become a little bit actual when we can run the filters longer times. Question will be again to all the speakers, but in first place to Craig.
I would comment, you have to, we are ultimately clinicians, and we deal with the patient at the bedside in a very dynamic way. I often anticipate, especially in your very septic patient, I would have a slightly different approach and say to myself, well, if I can get through to 48 hours in this very septic patient, who more than likely has large molecules, lots of inflammatory molecules, if I can get my filter to 48 hours, I will consciously make a decision to change the filter even earlier and 48 hours. I don't really need parameters to tell me, because I know my filter is going to clear very large molecules, and it's going to have a high burden of these molecules. And I may make a decision without any other measurements to change the filter within 48 hours. If I know my patient is fairly stable and my main problem is, for instance, fluid overload, and I just want to make sure that I'm getting some precision on fluid, and my patient has overcome his sepsis, I will push that filter a bit further on. Yes, if we want to measure on CRRT, which I do a lot, is I find that if I'm not altering my calcium compensation and my ionized calcium levels for most of my dialysis session, and all of a sudden I'm beginning to have to make a lot of little changes to my calcium compensation or my citrate dose, that for me is a telltale sign that my filter is reduced its surface area, and that I probably have to look at changing things. Really, I don't use things like there's a thing called the Funbund ratio, the urea nitrogen level in the fluid and the urea nitrogen level in the blood. I find it cumbersome. I find it unhelpful because it's a long turnover to getting these results. And if your Funbund ratio is, for instance, less than 0.8, that's a good sign that you're filter clogging and clotting. And then, of course, the obvious ones, which I'm sure Kamal has spoken about before, and he can tell us a bit more about it, is your TMP levels and your those kind of things that can help you to decide when the filter is beginning to fail.
So I'll add to Dr. Craig's remark is, yes, there will be some alarms that the system will generate, not clotting alarms, but alarms indicating that the pressure inside the filter is starting to rise, the filter pressure, the transmembrane pressure, and so on. And as Professor Broman explained that, the clearances will decrease. So, the clearance of small molecules like urea, creatinine will decrease by time, and therefore these kinds of ratios to size, how fast is the decrease. all this is fine, but also remember, if you're doing citrate, also the clearance of citrate will be less. So remember, when you have clogging, the filter is blocked. The hollow fibers are blocked with fats and proteins. And those protein cake blocks the clearance of urea, creatine, and citrate, being such a small molecule, will no longer be removed in the dialysate. So you will find out that the patient is receiving more citrate than he used to. And the machine doesn't see that, because the machine does not see that your filter is blocked, because, in this case, the machine will not increase this calcium compensation. So you will find yourself finding some readings where you will need to increase calcium compensation from 100% to 110, 120. Why? There is no reason why, except that the filter is clogging and that the citrate is going to the patient more than it used to. So it's a technical thing. And therefore, the good advice is to change the filter with or without clotting after the 72 hours to prevent these problems of clogging happening.
Yes. So a question to Dr. Kamel. I know that in the audience, there are many doctors who are not using citrate at the moment, and they hear about citrate, all the good talk about citrate. So what are the benefits of using citrate? This question is for Dr. Kamel. If an ICU department decides to introduce citrate, what benefit will we reach with that? This, I think, many clinicians ask.
And, thank you, Professor Bowman. This is very important to understand that, there is evidence showing that switching to citrate program, you will have, number one, longer filter lifespan. So if you're right now having almost 20 or a 24-hour, this will be a longer filter lifespan when you switch to citrate versus heparin or no anticoagulation. Now, we have this in many observational studies, but also we have it recently in randomized control trial from Germany that was published by Professor Zarbok, showing that longer filter, doubling almost of the filter lifespan when you switch to citrate. This is number one. Number two, less bleeding risk. So the same study also showed less bleeding risk. Why? Because we are anticoagulating the circuit, not the patient. So the patient is less likely coagulated on heparin, because in heparin, we are anticoagulating the actual patient. Here, the patient should be testing normal APTT, normal calcium, normal everything. So with citrate, we have evidence proving less bleeding risk, less blood transfusions. So this is the science. But also, when you switch to practice, you end up saving on costs of changing the filter, saving on the nursing, cost of nursing, handling alarms. You end up, saving on blood transfusions. So it's the whole overall cost of therapy. That's why it is the easier way and sometimes the cheaper way of doing CRRT. And that's why it's the most common worldwide. So in our region, I understand that no anticoagulation or heparin is more common. But on a global level, the number one modality is citrate anticoagulation for a good reason.
Yes, true. So these were my questions for this time. I will give the word back over to Professor Amr.
Thank you so much. It's a great webinar. And again, we have several questions regarding our November 18th and 19th workshop, masterclass and crash course. And we are going to be in touch. I don't want to waste our webinar giving more description about our upcoming event. So I will let Dr. Manu to share his take-home messages and to conclude the webinar. Just two housekeeping stuff here. First, by tomorrow, everyone should have an access to our recorded today's webinar. And by next week, everyone who attended this webinar should receive a certificate. And with that, I'm going to lead Dr. Manu to give the closing remarks.
Okay, thank you so much, Amr. Thank you, all colleagues, for these interesting talks. I'm just gonna give you some take-home messages, what I learned from today's webinar. I think, Amr, you kicked off nicely, reminding us that understanding CRRT begins with understanding the patient physiology, the trajectory, and so forth. Then we had an interesting lecture by Dr. Ibrahim, who illustrated a case-based scenario where we dove into filtration fraction, tried to understand what is citrate overload, citrate accumulation, and how we can detect this in our patients. Then I really enjoyed the talk by Craig Aronson, who reminded us that we need to use clear language when we talk about CRRT, and this is important for effective communication within multidisciplinary teams. And then the final lecture was by Dr. El-Attar, who brought us back to the fundamentals, I would say, regarding regional citrate anticoagulation and what is behind each parameter within the CVVH machine. For me, I'm not a nephrologist, I'm an internist, intensivist. I like CRRT because it allows me to just set my ultrafiltration, net ultrafiltration in patients who are septic, who are fluid overloaded, fluid accumulated, with complete homeostasis of electrolytes. And this is something which can be very important and life-saving if we do it properly. So that would be my take-home messages. Thanks everyone from joining from all over the world. And yes, welcome to the masterclass crash course in November.
Thank you so much. I will see you back next month.
Bye-bye.
Bye.
Bye.